Good afternoon, and I am delighted. I'm Steve Higgins, the director of the Vermont Center on Behavior and Health, and this is the first of our lectures that is back at the Davis Auditorium, where we have an in-person audience and an in-person guest speaker. So I am thrilled about that. And but I want to welcome all those who are joining us remotely. Thanks for being with us, and we are on schedule to have a wonderful presentation. We have an excellent investigator, Quinn Pack, with us today, and I am going to turn over the introduction of Dr. Pack to my colleague, Diane Galima. Diane.
All right. Thank you, everybody, for attending. It gives me great pleasure to introduce our speaker today, Dr. Quinn Pack. So just to give the background of his extensive training, he did medical school at University of Michigan, and then did his residency at Wisconsin, and then did fellowship over at Henry Ford in Detroit, and then went to Mayo Clinic for a while. And now he has landed in Bay State over in Massachusetts, where he's been for almost 10 years at this point. But he serves there as a non-invasive and preventive cardiologist, as well as the medical director of the Cardiac Rehab and Wellness Program there, and is an associate professor of medicine as well. And in addition to all of his clinical duties, he is also quite the scientist as well, and has published over 50 peer-reviewed articles, and is also very active in our in the American Association of Cardiovascular Rehabilitation and Prevention, where you head the clinical care committee. Is that
the quality of care committee.
Quality of care committee. So multifaceted, highly trained, very impressive research portfolio. And we have a long history of working with Dr. Pack. He's worked with Dr. Filius for over a decade at this point. I've been friends and colleagues with him for over 5 years at this point. So without further ado, I will invite him to come up here and give his talk. Thank you, Quinn.
Thank you. Thank you. And for all of those who are online, welcome. This is great. It's my pleasure to be here. Thank you, Diane. Thank you, Phil. Thank you, Steve. I don't know if there are technical problems. Please figure out a way to message this. Otherwise, you may not be able to hear. So I'm going to talk about smoking cessation in cardiac patients. As a preventive cardiologist, I still like echo. I still like cath. But one of the neglected things we tend not to talk about is smoking cessation. And so I'm really excited to be able to give some of that, let's see, not volume, give that lecture. I have no conflicts of interest. I will tell you, I'm going to talk very briefly about some off-label NRT use. And I'm supported by 3 grants, one of which is actually trying to understand how to help hospitalized patients quit smoking. I like Mark Twain. He lived in Connecticut, Hartford. Giving up smoking is the easiest thing in the world. I know because I've done it thousands of times, right? This is a tough addiction, and it's been an addiction for 150 years. I'd like to start with a story that always sort of true story at Bay State, 53-year-old man with chest pain and a myocardial infarction. Cardiology world, he gets a stent to the mid-LAD. It's successful. He does have a large anterior MI on his echocardiogram, so his ejection fraction is reduced. He qualifies for heart failure therapies. He's discharged 2.5 days later, and he's put on standard therapy, aspirin, Plavix, high-intensity statin, beta blocker, ACE inhibitor. He gets a cardiac rehab referral. He even gets spironolactone. So, like, state-of-the-art medication, like, great. There's a problem, right? So cardiologists, we congratulate ourselves. Nice work. Cheers all around. We saved this man's life. The problem is that he didn't have hypertension. He didn't have diabetes. He was a smoker. And he was discharged on no medications. There was no documented counseling anywhere. I'm pretty sure that somebody said something, but there was nothing that was documented, right? He goes to his primary care provider. His primary care provider, as good intentions as possible, still says nothing, does nothing. He gets to cardiac rehab 3 weeks later. He's given advice, right? This was at one of our regional programs without a tobacco counselor. And then 6 weeks later, he visits with a cardiologist who prescribes him varenicline. That's the first time that something other than advice had actually been done. And this problem is replayed over and over again in US hospitals every day. We'll get to some of that data. But I think it's worthwhile to step back and sort of say, okay, we all know that smoking is bad, just how bad is it? And this is one of my all-time favorite papers, is what is it that actually kills people in America? We're all gonna die. What is it that kills us prematurely? And it's not heart disease. Heart disease is the end product of our risk behaviors, right? So risk behavior number one is tobacco, 485,000 deaths. That number continues to maintain at around 500,000 per year. Poor diet and physical inactivity is 400,000. So my favorite thing to do is to take a physically inactive smoker and turn them into a physically active non-smoker. I've eliminated the two most common causes of premature death in America. Alcohol is number 3. And for perspective, COVID in 2020 was 375,000. That's a tragedy. But there were more people who died of tobacco-related diseases in the year 2020 than who died of COVID. Similarly, opioid, for all of the bad things that it does, and it kills our younger population, only peaked at 70,000 patients per year. So tobacco is still number one. Okay, it's still number one of actual causes. Now, the cardiovascular mortality decline, right? We discovered that smoking was a risk factor in the mid 1950s, right? And if you look at this trend from 1900 to 1996, you can see that cardiovascular disease really peaked in the 1950s, 1960s, which is when Framingham started. And there's been this rapid decline. And this only goes up to 1996. Here is a layered, more recent one, and I'm actually going to blow this up. You can see that this blows up, and you can actually see the red line is the incidence of cardiovascular disease has leveled off and has started to rise again. And the risk factor that is rising rapidly is the blue line, which is diabetes and obesity. So over 50 years, we've seen declining heart disease. We're now losing the battle to diabetes and obesity. But I want to talk about what were the contributors to that decline, right? So here is the one of my favorite figures. It tells us that smoking is a 20th century epidemic. Yes, there was tobacco, but it was typically pipes, it was cigars, it wasn't inhaled in the lungs, right? The World War I, it became part of our rations. It was definitely enhanced in World War II, right? One of the things that enabled all of this was a process called basification. And I know many of you are familiar with this. It makes the nicotine easier to inhale, and it gets out into the lungs, and it increases the potency of the nicotine that's delivered. It amplifies the addictive potential. That was the thing that happened in early 1900. It wasn't until 1950 that scientists began to say, hey, let's worry about this. And then the first Surgeon General report came out in 1964. And basically from that point on, it's all good news until we get to sort of the master settlement. I think about my my grandfather, born in 1910, who got caught up in this. And he died at age 75. He had diabetes, but diabetes and smoking was a problem. And I think about this study. This is a study from the Lancet about 10 years ago. And it compares on the blue line smokers. This is about 1.6 million women. On the blue line is smokers, and on the red line is the non-smokers. And so if you look at this, let's see if I can get the laser pointer. Whoopsie. If you look at the laser pointer, the age at which the risk equivalent of dying is the same is age 80 versus age 69. A 69-year-old smoker an average smoker has a 24% risk of death at age 69. A 80-year-old non-smoker has a 24% risk of death at age 80. And so you can see that there is basically an 11-year difference. And so, the person I think about is my grandmother. My grandmother was a widow until she was 89. She lived 20 years on her own. And some of that was because my grandfather smoked. And that's the kind of stuff that we sort of talk about, is the widows and the widowers who lived those last 10 to 15 years. And one of the things I think about my grandfather, I remember him as very decrepit at age 70. He was not functioning. My grandmother had to do most everything for him. At that point, he was blind from his diabetes, and from the smoking, right? So anyway, that's what we're really talking about here. Um, I often see, and I know there's a cardiology audience somewhere out there. There's a few cardiologists. This is what I call the interventionalist view of the world, right? And I saw this published in New England Journal, and it just irritated me so. Because what they do is they take the same graph, they see the declining incidence of cardiovascular disease, and they put these clinical trials on here that sort of imply that these clinical trials were the reason why there's this declining incidence of cardiovascular disease. So like statin was developed in 1976, but they weren't widely used. Like it was, yes, these are discoveries, but this is sometimes how the interventional colleagues and the EP colleagues like to think about the world is that, oh, all these great things that we're doing are what's declining in incidence. But actually, people have actually looked at this. And so if you look at, this is analysis of what was it that caused the decline in England and Wales over a 20-year period. And there were some risk factors that got worse. Again, if you look here, diabetes and obesity, even back in 1990s was getting worse. So this is a worsening, right? Some treatments did make a difference, but when you put smoking right here and sort of all risk factors comparing to all treatments, smoking cessation is the most important contributor to the decline in cardiovascular disease over the last 50 years. So we know that it works. And again, to my interventional colleagues, please teach your patients to quit smoking. All right, so here's the 2017 smoking rates. Utah and California lead the nation. The Mississippi and Ohio River valleys are the worst places. Vermont's actually pretty good. But it is still, even at 12 to 15% nationwide, it is still a big deal. The pandemic did not do good things for smoking cessation. We've seen at least a stalling of the decline in smoking cessation rates. I really like this paper that shows that the slope of the decline in the Clinton era, tobacco was declining in incidence during the Clinton era. It sort of steepened during the George W. Bush era. And then with the Tobacco Control Act, Obama was able to see a more rapid decline. So much so that people are now talking about an end game, right? Where if you continue at this slope, we might actually be looking at maybe in 2050, 2045, an end of the tobacco epidemic. Now, I still think there's a lot of work to be done because the people who still smoke are a harder group to reach. They're more socioeconomically disadvantaged. But there is potentially an end game in sight. So anyway, let me just back up and say, how many tobacco-related diseases can you think of? Just take a minute and sort of think about them. You know, most people think about coronary disease. People think about stroke. Peripheral arterial disease comes up, right? One of the ones for the electrophysiologists, if there are any, is sudden cardiac death. Sudden cardiac death is actually, smoking is a potent risk factor for sudden cardiac death. Coronary disease, myocardial infarction, right? 50% of the STEMI patients are smokers. Half of the smokers who wake the interventionalist up in the middle of the night, half the people who wake them up are STEMI patients, right? We think about peripheral vascular disease. Don't forget about aneurysms, definitely part of this, and then stroke, right? These are the ones that the cardiologists tend to think about, but there's a lot more, right? There's COPD. We know about emphysema, chronic bronchitis, asthma, pneumonia, and all of the lung infections that go with that. Don't forget about osteoporosis. Here's your bone disease, right? Don't forget about pregnancy problems. So premature birth weight, low weight for gestational age, pregnancy complications, prolonged labor, miscarriage. Then there's peptic ulcer disease. There's colon cancer, DVT, pulmonary embolism. Let's keep going. We haven't gotten to the cancers yet. Cancers include lung, throat, tongue, pharynx, esophagus, stomach, right? Kidney. The kidney has to filter all of those carcinogens that are smoked every single day, right? The bladder, pancreas, uterus, cervical cancer. The list goes on. And actually, here is an analysis from the Lancet of sort of the odds ratios. And there's a couple other gems in here I didn't know about. You can see that cirrhosis, diabetes, and breast cancer are also on this list. So There is actual pathophysiology that's been worked out about how smoking increases risk for diabetes. So it's a bad disease. All right, let's switch up a little bit, and maybe the psychologists will find this interesting. Talk a little bit about physiology. So in order, we have these. There are a lot of addictions: alcohol, caffeine, cocaine, heroin, marijuana, tobacco, and they're in no particular order. Anybody here wanting to guess what the former addicts tell us is the hardest thing for them to quit? So cigarettes is number 2. Cocaine turns out to be number 1, but cigarettes is right behind. It's worse than heroin. Heroin seems to be easier for people to quit. When you go to Alcoholics Anonymous, there's people's out in the hallway smoking, right? They've been able to kick the alcohol, but they haven't been able to kick the cigarettes. Marijuana, and for all of you who have caffeine withdrawal headaches, I'm sorry. It's a relatively easy addiction to kick. All right. So I feel sorry for these people. It's a chronic disease. You just work with them. You take them where they're at, and you continue to work with them, right? One of the problems with nicotine, right, is when we look at drug delivery, particularly as a cardiologist or a pulmonologist, inhaled nicotine is about as perfect as you can get for an inhaled drug, because right, the nicotine goes straight from the lungs to the left ventricle and to the brain. And people have worked out that the total transit time is about 7 seconds. Okay. If you do the same thing for an IV medicine, it has to find its way to the right ventricle, through the lungs, to the left ventricle, and then up to the brain. In code situations, we sometimes use inhaled medications because that's sometimes the fastest way to get medications in, right? If you put on a patch, it's even slower. It has to sort of ooze through the skin to find its way to the venous system, to find its way all the way to the brain. So inhaled nicotine is just so potent. The signals arrive at the brain so quickly as to just produce that relief. It just makes this so much, it makes it just ideal for nicotine delivery and for addiction potential. Now, this actually tells us that pharmacology for treatment has some non-addictive potential, right? So with the exception of maybe the nasal spray, nicotine replacement of therapy arrives too slowly at the brain to produce addictive reward potential. So this is a nice pharmacologic study where they basically measured the nicotine levels in the blood every 10 minutes and had people smoke, chew a gum, take a cigarette, or use the nasal spray. And you can see pretty convincingly that the cigarette is the item that produces the very fastest gain in nicotine levels. And in fact, it's kind of too bad that they didn't measure something at 3 minutes, because at 3 minutes, I think you'd see even higher spikes on nicotine. So you get this dramatic rise in nicotine, but then you compare that to, say, the patch. Well, the patch is very slow. It takes almost 2 hours for it to reach even sort of a typical potential where you're going to start seeing the gum is slower, but a little bit faster. And so one of the things that this teaches us is that the patch is not really going to reproduce the dopamine rewards. It's not going to be addictive. The gum is not typically going to be addictive. It's just too slow. It's fast enough to prevent withdrawal. It's fast enough to, in some cases, help treat cravings. But it's not, I just don't know anybody who's ever been addicted to the nicotine patch or the gum or the lozenge. It just doesn't happen, right? And it's because of the pharmacology. So again, right, in the US surgeon, they've said tobacco, it's definitely addictive, right? We continue to use it even though it hurts us. Symptoms of withdrawal. And for any doctors in the audience, you do see this, right? I remember a patient who had been 2 weeks without a cigarette, walked into cardiac rehab and was visibly shaking, like was almost tearing up and was like, I just can't handle it. I'm just like dying. And she was on a 14 milligram patch, clearly underdosed. We doubled it to 28. She came back the next day and she said, I feel so much better. Right. But if you look for this in the hospital, you'll find it. And particularly in that 1 to 2 week is when you see it. It's when they peak. So you see this dysphoria, depression, insomnia, irritability, anger, anxiety, restlessness, decreased heart rate. It can be observed in the hospital. I like this graphic, like it sort of makes you feel crazy. I remember a patient that I saw. I had seen her in the hospital. I prescribed adequate dose patch. And then she came back to see me 6 weeks later. And she said, and I said, how are you doing? She's like, I haven't smoked at all, but for the last 2 weeks, I've been miserable, grouchy, irritable, angry. And it's like, oh, wow, that's a lot to deal with. And I kept going on. And I later said, well, tell me about your medicines. And like, I'm on this, and this. And I'm like, okay, are you still using the patch? She said, no. And it's like, oh, when did you stop? About 2 weeks ago. And I'm like, well, that's why you've been grouchy, irritable, angry, and upset. She actually managed to, we got her back on the patch and she's done very well. She hasn't had a cigarette in like 5 years. So I was super proud of her. But like she stopped taking the patch after a month, because she thought she was done with therapy. And then she suddenly was having all these withdrawal symptoms. Nicotine cravings are a little bit different than withdrawal, right? They're very sensitive to environmental cues. So the morning coffee, driving in the car, phone calls, meals, alcohol, right? They do decrease with time. But I've had smokers tell me that the cravings never completely go away, at least for some, right? So this is something they may have to deal with. They do extinguish over time, right? Now, in a hospital setting, I hear this all the time, right? Oh, I won't have a problem when I get home. I've already quit. I'm not having withdrawal. I feel great. It turns out that, again, in truth, withdrawal really peaks 1 to 2 weeks after smoking cessation. And actually the fact that hospitals prohibit smoking is smokers know they can't smoke. And actually that really reduces their cravings. So just laying in a hospital bed reduces cravings. Having an IV, having a cardiac catheterization, talking to surgeons, that reduces cravings. When they walk home, they're gonna have their dog, their phone, their news feed, their coffee, their cigarette ashtrays. It's all gonna be there, and the cravings can go wild. So whenever somebody says this to me, oh, I'm not having problems, I say, yes, but what about when you go home? And I've had patients say, oh, I'm not gonna take any of your medicines. I'm like, can I at least prescribe them so that they are readily available to you for when you get home and start having cravings? Because I know you're going to have cravings when you get home, right? So anyway, the reality is that despite all these good intentions, most smokers relapse, right? 80% of smokers want to quit. Most of them eventually relapse. And this is one of my favorite slides. This comes from a trial at CMAJ where they were comparing varenicline to placebo. And you can see the time after randomization goes from 0 to a year, or in 52 weeks. And the smoking cessation abstinence goes from 0 to 100%. And you can clearly see that varenicline in the dashed gray line beats placebo, okay? That's not what's interesting about me. We know that varenicline is good. What's interesting to me is the slope of this curve. This is not linear, right? The difference between 1 year and 6 months is a 2% difference. The difference between 6 months and 3 months, even 1 month, is about an 8% difference. But if you look at the difference between week 0 and week 1, that's where all the action is. It's in that first week. And so the median time in this study to relapse is within 7 days. And I found one study where, again, these are people in a randomized controlled trial who are motivated to quit smoking. 5% of them are relapsing within 1 hour. They're walking out, and some of them have even said, I walked out and I lit up without even thinking about it. I had already smoked my first cigarette and I was 30 minutes out of the hospital. So at least for me, right, this is a call to action, that in the hospital is the moment to intervene, at least with the cardiac patients. You can still intervene with them in clinic, and you absolutely should. But the moment to intervene is in the hospital. And I consider it like, if you're going to jump out of an airplane, put on your backpack, have a buddy there, get all your tools so that you don't crash land, right? That's what you're really trying to do. So one of the papers that we did, and I sort of sense this, is that most smokers don't get any treatment. So we published this in JAMA Internal Medicine 5 years ago, where we looked at about 500 hospitals across the United States. At an average hospital in America, only 20 to 25% of patients get any medications while in the hospital. That number drops in half at the time of discharge, And these are both clinician and hospital dependent. So some hospitals do great, some hospitals do terrible, some clinicians do great, and some clinicians do terrible. But in general, these medicines are just not used after acute coronary syndrome. And so to summarize sort of the epidemiology and moment here, Michael Fiore was my first mentor. He wrote this in the 2008 guidelines. I just love it. He says, tobacco use presents a rare confluence of circumstances, a highly significant health threat, a disinclination among clinicians to intervene consistently, and the presence of effective interventions. Indeed, it is difficult to identify any other condition that presents such a mix of lethality, prevalence, and neglect, despite effective and readily available interventions. And I just think about this a lot. There's so much we could and should be doing for these folks, yet it just gets pushed aside. Sometimes we're just so busy that the time to really focus on it just never arrives. So let me switch up to treatment, because again, you guys know the epidemiology. You sort of understand these things. Let me take you back to Fellows Clinic about a year and a half ago. I kid you not, there were two fellows, same day. They both came up to me and said, my patient's tried everything. Dr. Pack, I give up, right? And the first patient had quit for 7 days on a nicotine patch and then relapsed. And so she said, yeah, that patch doesn't work for me. And then she tried varenicline and had abnormal dreams. And I think that she'd also tried the gum or something. Patient 2 had quit for 4 weeks on varenicline and then relapsed. And then had tried the 14 milligram patch and had tried a 2 milligram patch. And so, I said, well, I started talking to the fellows. But anyway, put these two cases, we're going to come back to them. What would be the questions you would want to ask these folks? Right. Well, the best guideline that we have right now is this 2000 ACC, American College of Cardiology Expert Consensus Pathway. It was authored primarily by Nancy Brigatti, although she's not a cardiologist, so she couldn't be first author. And this were the key points, right? Treat tobacco as a chronic relapsing disease. Okay. Just always keep it on the problem list. Gently talk to those patients. There is evidence that even just telling a patient to quit smoking does reduce mortality. They do quit, though the effect is small. You are not wasting your breath to tell your smokers to quit smoking. Keep it on the problem list. Make sure that you still continue to address this. You can look through this flow sheet, keep track of the former smokers, keep track of the daily smokers, ask them, assess them, advise, offer and connect them to treatment, and then follow up with them. And this isn't a follow-up in 6 weeks or 6 months. This is a fairly rapid follow-up. That's recommended in the guidelines, right? Counseling. We use motivational interviewing. We use skills training. We use self-monitoring, stress management, mindfulness, alter the environments, avoid triggers, particularly avoid alcohol, right? These are things that I don't think most physicians do, but they can be used, right? Psychologists do this. There's smokefree.gov. I really like smokefree.gov and 1-800-QUIT-NOW. If you can actually have a patient, I want you to go right now to smokefree.gov, and I want you right now to sign up for the text message. The system, it takes about 3 minutes, and then they go. And then they've got support for the next 2 to 3 months, right? These psychosocial supports really do work. In some cases, patients can get free medications, right? We've been told about the ask, advise, assess, assist, arrange. If you have a patient who you're having difficulty connecting with, talk to them about the risks of smoking. Talk to them about the rewards of quitting smoking. Assess their roadblocks. Make sure that they understand that, yes, their bypass surgery is related to their tobacco use. And then this repetition, right? There's a lot more that's been written on those, but I want to switch up to medications. So, this is the glass half empty, glass half full. I hear patients tell me all the time, oh, those medicines didn't work. And they didn't make me quit smoking. And my next question is, did they help? And actually, almost all of the time, I can get a yes to that. Oh, yeah, I had less withdrawal. Oh, I had less cravings. Oh, I was able to reduce. But those medicines didn't work for me. No, that's a glass half empty. Like, what the medicines can give you a chance to deal with all the psychosocial behavioral issues that come along with the entrainment and the exposure cues, right? So just because most people fail doesn't mean they don't work. So I'm very much a glass is half full, right? So I know most of you know this, but it's worth mentioning. Nicotine replacement is one of the most common therapies, right? It's an active ingredient. It does not cause cancer, okay? And it doubles a patient's chance of quitting. Now, nicotine replacement therapy has traditionally not been used in the cardiac ICU. But again, in one of our studies, we found that it's up to 20% of patients are used it. And we did this retrospective analysis. We took 27,000 patients, a third of whom were in the ICU. 18% of them got NRT in the first 2 days. And then we did some propensity matching and a lot of adjustment. And we found no difference in mortality, no difference in length of stay, no difference in cost, and no difference in readmission. We concluded that NRT appears to be safe even in the intensive care unit. Okay, so I don't think that just because someone is having a heart attack, that's a reason not to give them NRT. And in fact, I've actually seen where withdrawal becomes a bigger problem than the NRT does. We know the nicotine patch, again, doubles somebody's chances to quit. The common side effects is a rash, right? People put the patch and you can rotate sites. And if you have a really bad rash, add a little triamcinolone. Some people talk about bad dreams to the patch, right? Well, lower the dose or remove the patch at bedtime. This one will work, right? People often say, oh, I'm not allowed to smoke while on the patch, right? The FDA got rid of that about 10 years ago. You are allowed to smoke on the patch. That actually opens up the possibility of saying, well, here's a patch I want you to reduce. Okay, you're smoking 20 cigarettes a day. I want you to try 21 milligram patch. And if we get down to 5 cigarettes a day, that's a win, right? So reduction, harm reduction is a strategy that allows you to smoke on the patch, but just use less cigarettes. And actually, it's been proven that if you can get a patient who's not motivated to take a patch, and then they suddenly find themselves smoking a whole lot less, they get very motivated to actually completely quit, right? This is another study where I've always sort of known this. One of the reasons the nicotine patch doesn't work for a lot of folks is that it's underdosed. Okay, and so here is a really nice pharmacologic study. But the net result is that the 22 milligram patch replaces only about half of a 1 pack a day smoker's baseline nicotine levels. So you're not going to even prevent withdrawal here, much less manage those cravings. So but they found no toxicity at 44 milligrams, right? And so if you were to walk away with sort of one piece of advice on the nicotine patch, it's that 1 pack per day is not equal to 21 milligram patch, okay? A 7 milligram patch is almost placebo, okay? Except for if it's added to something else. I rarely use the 14 milligram patch. If I have a half a pack a day smoker, I give them a full 21 milligram. And then again, right, by extension, rare use of the low dose gum or lozenge. At the same time, that opens up this question, should we be using doses higher than 21 milligrams? And the answer to that question is yes. There's been 1,500 patients who've been trialed at much higher doses, including 3 patches a day, right? They did not find serious side effects. They found some short-term effects. The long-term effects are mixed. And so titration really seems to be the key. If you've got a 2 pack a day smoker and you send them home on 21 milligrams, you've replaced maybe a quarter of their baseline nicotine levels. That's just not going to be enough. They probably need to be on 42 milligrams, okay? Or at least you need to titrate that. Put them on a 21. Tell them if it's not enough, add a 14. If that's not enough, they can add 2 21s and so on and so forth. And again, higher than 21 milligrams is an off-label use, but again, I think it's a well-studied off-label use. Again, the nicotine gum and lozenge, right? One of the things that I see that's a mistake is patients will just chew it like it's regular gum, like they're trying to get the sugar out. This is a chew and park. You chew, and then you wait, and then you chew, and then you wait. And if you use soda or coffee, that reduces the pH of the mouth and it won't work. They won't get any absorption. The absorption is from the gum through the oral mucosa. That's where you get the nicotine, right? And hiccups, dyspepsia, those are very common, particularly if you're swallowing the nicotine, right? So this is meant to be absorbed through the mouth. The nicotine inhaler, this is not an e-cigarette, right? Also doubles a person's chance to quit. I don't use the nasal spray because I think it has a little bit of addictive potential. The inhaler, some people really like having something to hold on to. But it is also, the inhaler does not get down into the alveoli of the lungs. It's absorbed through the oral mucosa. So it's not a particularly fast medication, right? And then finally, don't forget bupropion also works very well. The common side effects of that are insomnia and dry mouth, right? Don't use it in patients with seizures or heavy alcohol. And then varenicline, right? It's a partial agonist of this alpha-4 beta-2 receptor. It's the most effective agent on the market. It starts with a starter pack, so that's in blue, where the dose is lower to begin with. That helps avoid the nausea, which is the most common side effect. If you up titrate slowly, you mostly avoid the nausea. And if the most common thing that I hear people say is, oh, I had vivid dreams. And the solution to this actually is to not take the evening dose or to reduce the dose. Take the medicine only in the morning. This works nicely for avoiding vivid dreams. Again, we talked about combination therapy. You can use the patch and the lozenge, a patch, the inhaler, bupropion and the lozenge, varenicline and the patch. You can reuse varenicline and bupropion, just like you would use different formulations of insulin in combination with each other. And the more combinations you use, in generally, the more effective that you get, as long as those medications are well titrated. So the guidelines, again, quite clearly come back and say pharmacotherapy should be encouraged for virtually all daily smokers. They actually make a recommendation. First-line medications are varenicline and patch plus an ad lib NRT. So I generally do not think sending someone home on a 21 milligram patch is sufficient. It's not enough. Give them something else. And even in an ideal world, I would actually go with varenicline plus a patch plus a lozenge. Varenicline is slow, so they're walking out the hospital door. That's going to help them long term, but they need that patch for sort of that first drive out of the hospital and that lozenge for those first cravings. Here's the very busy table. This is in the guidelines, and it has got all the details on how to prescribe. So if you want to know the exact details, the common side effects, it's all there. If I was going to summarize sort of one thing, this is the way I put together, like this is the guidelines according to Dr. Pack, okay? Really, you shouldn't be using low-dose nicotine patch. You should not be using it for only 4 weeks. And if you have a lapse, you shouldn't stop, right? Those are all less effective ways of dealing with it. We know the nicotine patch, when it's adequately dosed, is effective. The gum, the lozenge, bupropion, that's effective, right? More effective than those is varenicline or combination therapy or bupropion plus NRT with 3 months of use. And then the most effective is varenicline patch, nicotine replacement therapy, varenicline plus bupropion, and 6 months of use. Okay, I'm going to go over a little bit more of this data in a little bit. So let's go back to the fellows clinic. All right, so I'm back in fellows clinic. I've tried everything. Well, we talked to patient one. I kid you not, this was exactly the same day. She had taken the patch for 7 days, hadn't had any urges at all. She was feeling great, but she wasn't rotating her skin site. So she said, I kept putting the patch on and it just getting more and more irritated. The fellow had not picked up on the fact that she was having rash. And so we just told her to rotate the site. She was also said varenicline caused abnormal dreams. So we dosed it just in the morning. So she went home with patch and varenicline, right? The second patient had quit for 4 weeks, hadn't had a single cigarette on varenicline. And the reason she didn't continue varenicline was because she had completed her therapy. No one had prescribed a refill. That was it. Varenicline was working marvelously for those first 4 weeks, but it just hadn't been continued. No one had bothered to put in a refill. And the 14 milligram and 2 milligram gum patch was ineffective, probably because they were underdosed. Okay, and she had never used a combination. So in both cases, with just a few questions of probing, we were able to quickly find a medication combination that worked for both of these patients. All right, so finally, I want to just talk about a few misconceptions, because I hear these regularly, and again, they get repeated. So, we talk about people who want to cut down, and there's this assumption that if a patient has been cutting down, that they're having less nicotine addiction. That is actually not true, right? So how much nicotine you get out of the cigarette depends on how hard you try, right? So you can breathe deeply, you can hold for a long time, you can be very careful about how you get the nicotine. So it is possible to get the same amount of nicotine out of 7 cigarettes as you might have gotten out of a whole pack per day. All right, and actually, that's this. Anybody in this red box are people whose nicotine level were at the same or higher, despite having cut down on the number of cigarettes. So one of the reasons that this matters is that if you've got somebody who says, you know, I'm down to 5 cigarettes, Dr. Pack, I've seen people say, oh, okay, well, then you only need a 7 milligram patch. Well, no, I was actually a 1 pack a day smoker before I cut down to 5, and I'm still smoking them really hard. That's someone I would give probably at least a 21 milligram patch. Someone who's cutting down but isn't back. I often ask the question, how much would you smoke if you could just smoke and you weren't trying to quit? Oh, I would be a 1.5 pack a day smoker. And I'd smoke the first cigarette within 30 seconds of waking up. You're like, okay, you need a lot more nicotine than the 7 milligram patch. All right. The second one that comes across is that there are a lot of people who think the risk with smoking is per cigarette. And unfortunately, at least in cardiovascular disease, that's not true. That's a little more true in cancer. It's more linear in cancer, but in cardiovascular disease, it's this sort of reverse logarithmic slope where if you look at just the first cigarette, that's almost half of the risk of a full pack per day. All right, so secondhand smoke is not good. It only takes even just that first cigarette. So there's a tremendous amount of harm. This was actually verified in a very nice study. This is about a year old, where they took 900,000 smokers in 3 different waves, and they looked at 4 statuses: those who quit smoking and stayed quitting, those who were sustained smokers, those who reduced by more than 50%, and then those who relapsed. And let me take you through this chart. So here, if you increase, sustain, or reduce mildly, you basically see no difference in outcomes. It's only the quitters that see the reduction at the very bottom here, 25% reduction in cardiovascular MACE, okay? But then you look at those who continue to stay quit, and they remain. Those who relapse see a 40 to 50% increase in their risk. And it doesn't matter whether you fully relapse, or you partially relapse, or you only marginally relapse. So again, really the only status that counts, take this with a grain of salt, is complete abstinence. The reducing is good, but reducing has to be a means to the end. That makes sense if you want to really reduce cardiovascular risk. All right, here's another one I hear. I hear patients tell me, oh, Dr. Pack, I can't quit right now because I'm too stressed. My cat's uncle's brothers died, and I've got a funeral to go to, and the lawyers are after me, and the car agent is bothering me, and I just can't not do it. But the problem is that the nicotine actually reinforces the anxiety. The nicotine reinforces the stress. And there's a very nice meta-analysis that looked at the changes in depression, anxiety, stress, and quality of life with smoking cessation. And the answer is very clear that smoking cessation improves mental health. Okay, it improves anxiety, depression, mixed anxiety, and stress. And the effect size is equivalent or larger to antidepressant medicines. So when a patient tells you, I'm too stressed to quit, I mean, I usually say, well, I understand that's really true, but they are in some ways actually blowing smoke in your face. Okay, because you need to tell them, I know it's hard, and you're going to be anxious, and you're going to be stressed, and you've got to do it, but you are going to feel better. You will be less stressed and less anxious once you've quit. Because riding the highs and lows of withdrawal and cravings, and then feeding this addiction, it actually amplifies stress and anxiety in life. All right, so here's another one. And this one I get from cardiologists more frequently is, oh, I can't use varenicline, it causes suicide. And so the FDA went to Pfizer and said, you have to do a big safety study. So they did it. And that study is the Eagles trial, and it's been out for 7 years now. Okay, 8,000 patients. Half the patients had a neuropsych disorder. So depression, anxiety, prior suicidality, schizophrenia, all kinds of mental health disorders. They had to be stable. They were not actively in the hospital, not currently suicidal. Big multi-center study, and patients got, this was like a triple dummy study. So they got placebo, varenicline, bupropion, or a nicotine patch. So every day, everyone took 2 pills and a patch. Okay. The placebo group got a placebo patch, and 2 placebo pills. Okay. So there was a perfectly done randomized trial. Here's the results. Just look at the red. Varenicline, this is basically the 3 month outcomes. Varenicline is the leader. 33% of the smokers quit. Bupropion and patch are close behind at 22%, and placebo is at 12%. So varenicline is the top of the game. It's the best medicine. If you have a chance to use it, that's the medication. That's not why they did this study. The reason they did this is for the side effects. In the non-psychiatric cohort, you can see here that it was about a 1 to 2% incidence of something new, another episode of major depression, another episode of schizophrenia where you had to be hospitalized. No difference between arms. If you look at the psychiatric cohort, it was a lot higher. It was 5 to 6 to 7%, but no difference between arms. Okay, so what this tells you is that the act of quitting smoking, the attempt to make the behavior change, is the thing that is causing some of these psychiatric side effects. It's not the medicines. It is not the medicines. Patients with a prior history of depression, with a prior history of suicidality, yes, they're at higher risk. But it's the attempt at smoking cessation, which is what is the trigger here, not the medications. All right. So anyway, after the FDA saw this, they got rid of the black box warning, and I use varenicline in my depressed smokers. I don't give it to patients who are suicidal. Okay, I want to make sure that they're stable, but other than that, I go ahead. And again, smoking cessation is the risk factor for mental health. All right, then there's this other question of how long do we prescribe? This has been done with both varenicline and NRT. They took 500 smokers in this trial, 8 weeks, 24 weeks, or 52 weeks. And basically the answer is that you should treat for 3 to 6 months. If you stop at 2 months or at 8 weeks, you lose a lot of folks that you might have maintained had you held on a little bit longer. So the minimum standard for me is 3 months, and I usually say 6. And in some cases, I've gone for a year because that's what patients wanted. All right, here's another one. I have patients who say, oh, Dr. Pack, I don't want to quit smoking because I'm afraid to gain weight. Okay. And it is true that most smokers gain 10 pounds. It's a lot. And there is an increased risk of diabetes. Okay. But it's that weight gain is not all fat. So this is one of my studies. Actually, a third of that is lean body mass. And without any exercise training, bone density goes up and muscle strength goes up with quitting smoking. So some of the weight gain is healthy weight gain, right? And then we also know that mortality decreases. Even though there might be a slight increased risk of diabetes, some weight gain is important. And this comes out of New England Journal. And if you look at the up here, right, the weight gain after quitting, the green are the people who lost weight. The blue is people who gained up to 10 pounds. The orange is people who gained up to 20 pounds. And the blue is the 20 or more kilograms, or 22 or more kilograms. And if you look, the very best weight gain is between 10 and 20 pounds, is this orange line. And there is a statistical difference between people who gained 20 pounds versus those who lost weight. So everyone reduces their risk. Okay, everyone reduces their risks. Quitting smoking is good, right? But those who gain a little bit of weight, that's a favorable prognostic sign. So I try to reassure my patients that is not the most important thing in the world. And I have had small cachectic women who have come in and they just look so ill. They look like they've got chronic bronchitis, and they quit smoking and they gain a little weight and they look healthier. They feel better, right? So some weight gain is certainly important. So if I was going to summarize, basically here, I think we're approaching the end. If my optimal treatment for a hospitalized smoker would be some of that personalized counseling and medication prescription, right? While hospitalized, get them ready, get the medicines on before they walk out the door. I would, if they would let me, I would always go for varenicline and combination and maybe all of that together. And I always prescribe 6 months of medicine right out of the bat. They get a 1 month refill, or they get 1 month prescription and 6 months worth of refill. Okay, just straight out of the bat. I would actually hook them up with smokefree.gov, get them on a text messaging system, or hook them up with Become an X, or I could send them to the quit line. I know Vermont has a quit line, Massachusetts has a quit line. Actually actively refer. They need counseling quickly. So they walk out of the hospital and you're following up with them in a couple of days, 3 days later. Oh, can we adjust something? Do we need to go up on the medications? Do we need to give some additional stress techniques? Because most smokers with just pure grit can manage 48 hours. But after 48 hours, they need strategies, right? Cardiac rehabilitation has been nicely shown to help maintain smoking cessation. Long-term medications, again, 6 months of follow-up. So, I gave this lecture to our fellows about 2 years ago. And one of my fellows then sort of asked me, like, Dr. Pack, like, what can we do in our hospital to actually change this? Because I'm so busy and everyone else is so busy and I don't know all this stuff. And how can we actually solve this problem? And so that's actually where one of my grants came from, was this idea that in order to overcome these barriers, you need new strategies, right? So this is our conceptual model for the R01 that we've been funded to do. And basically the evidence-based practice is that you should counsel patients and do an inpatient assessment, that you should do tailored smoking cessation medications in virtually all patients, and that you should provide at least 1 month of supportive counseling as an outpatient. The barriers are that most physicians don't have time and they don't feel an urgency, right? Many clinicians don't have the experience of really prescribing these, right? There are some patients who don't understand how to use these medicines correctly. And then again, there's just a limited opportunities to follow up. Well, our strategies to improve this implementation problem is to get a dedicated team. And this is going to be a nurse practitioner and tobacco treatment specialist. And they're going to just take care of it. Okay. They prescribe directly to the patients. They prescribe directly at the time of discharge. And then we're going to do medication-based adherence counseling. We're going to try to solve some of these misconceptions with our patients. And then finally, we have a text messaging program, which we're going to try to help keep them connected to our team so they get up in trouble, they can get medications. We're going to help try to sustain their motivation. And the key outcomes for this mixed implementation effectiveness study is guideline concordant medication use after 7 days. Are they on varenicline and or combination NRT? Are they adhering? Do they like it? Is it sustainable? We're going to be looking at effectiveness, smoking cessation rates at 6 months and cigarettes per day. We're going to be then looking at cost effectiveness. Now, this is something that the payers care about, the insurance companies, the accountable care organizations. If we can show cost effectiveness, we're going to go to our accountable care organization and say, we need a little bit of money to keep doing this. Okay. Then we're also doing a cost revenue analysis for our hospital. Our hospital doesn't care if the insurance companies save money. They only care about their bottom line. And so that's this cost revenue analysis where we're going to have the nurse practitioner billing for using evaluation and management codes to actually help support his or her salary. So we have a nurse practitioner who's going to be involved, is going to be creating the bills and trying to make enough money that the hospital's good to subsidize it. And then of course, we'll be looking at some of the bigger ticket items, which is 30-day readmission. And there is some economic data to show that actually smoking cessation programs actually help reduce readmission. So we hope we can hook our hospital into supporting this service longer term. Here's a little bit more. We're going to be randomizing 424 patients. It's a 1-to-1 randomization. We've already talked about outcomes and sort of the on top of enhanced usual care. So we're hoping to start enrolling our first patient here in the next month. We may not quite make it, but I think by January we'll be going. So I'll just add this last little tidbit, is that when you look at the economics of smoking, cessation, particularly in patients with cardiac disease. The evidence is absolutely compelling. There's really nothing else in cardiology that is more cost effective than smoking cessation. So even though it may take you 3 extra minutes or 5 extra minutes to prescribe that medication, to counsel that patient, to connect them to services, it's one of the most cost-effective things you can do. Here we go. If you look at, this is a study that sort of compares cardiac rehabilitation. One of my other favorite therapies is less cost-effective than smoking cessation. But cardiac rehabilitation and smoking cessation kick cabbage, like it's not even close, right? The number of QALYs gained for a smoking cessation program, it's about $5,000 per QALY. For bypass surgery, it's about $100,000. Okay, for quality of life years gained. And PCI, again, also very expensive, also not as nearly as cost effective as tobacco. So with that, I'm going to say thank you. I'll be happy to take any questions, and thank you very much. Perfect. Great. Yeah. Yeah. So the question is where does e-cigarettes or vaping fit into here in terms of treatment? And actually, the answer to that question is I have recommended vaping to about 3 patients, but my usual experience is that they were using the patch wrong, they were underdosed, they didn't try varenicline, we didn't manage their abnormal dreams, we didn't manage their nausea, and actually once I actually dig deep enough into that, there isn't much of a role for e-cigarettes. That being said, and you probably know this in England, e-cigarettes are like the main treatment. England is primarily producing a harm reduction strategy. I find that I don't need it, but I have recommended e-cigarettes to a few of my patients when I'm like, okay, have you tried e-cigarettes? Like, we talked about this, we talked about this, we talked about this, we talked about this. Give it a try, because I do think there is some good data for harm reduction. We're not including it in our trial as one of the things because, again, my experience is that these medicines are mostly misunderstood and misused. And once you actually are prescribing them correctly, you can get patients on something that works for them. Oh, okay, we got.
I'm going to give a go with the handheld mic in the hopes that it's picking up online. If others in the audience have a question, then I'll pass that over. From Mike Cummings online, how do you address patients who are resistant to quitting? How about patients who are cutting back on their smoking by switching to an e-cigarette?
Yeah. So again, this is a chronic disease. You don't win all your battles in one clinic appointment. So you put it on the problem list and you keep working on it. And it's gentle reminders. And what happens is, it might be the 10th time that they try to quit that they succeed. So you just keep going on it. And then again, same thing with e-cigarettes. I think that as a population strategy, e-cigarettes probably make sense in a clinical setting. There's enough concern that I'm not sure I want people on e-cigarettes long term. There are studies that show that e-cigarettes, again, right, if you're going to use an e-cigarette, you must completely switch. Dual use provides no benefit at all. If you're smoking a few cigarettes and then you add an e-cigarette to that and you don't completely quit the combustibles, you've had no health benefit gain. But then those who do completely switch tend to just have exchanged. So they use e-cigarettes forever, right? As opposed to e-cigarettes as a bridge to complete cessation. So that's my issue with e-cigarettes, is that they replace the cigarettes, and we don't know the long-term toxicities. We think that they're lower. The preliminary data looks pretty good, but then you get things like the e-cigarette toxicity, right? Because people are vaping marijuana oils with vitamin E acetate in them, right? There are things that are going to happen that we just don't know enough with e-cigarettes.
Hi, Dr. Pack. Thank you so much. I'm Katie Benson. I'm a pulmonologist. I think the biggest thing I struggle with, and I'm curious about your position meeting people in the hospital, is because even patients that I have established relationship with and trust, they still come with all this baggage of having tried to quit in the past. You know, with Veronica getting pulled, voluntarily recalled last year, like it's just so hard to establish that trust. And I wonder if you have any tips or expertise with success.
Yeah, I one of the things, and I've had this experience, and I have to be honest, I'm not 100% sure what it is that I do. But I've had this experience where patients tell my residents and my fellows, "Oh, I'm never smoking. Don't even talk to me. I'll get angry if you do." And then I go into the room and I sit down and I just back way up and I say, "What is it that you like about smoking? Tell me what is it. Well, is there anything you don't like about smoking? Like tell me about those types of things." And suddenly and one of the things is that I've gotten deep enough into this that I understand sort of those cravings. I think I've never smoked myself, but I've had some addictive moments in my life where I've had cravings, where I have had urges, where I've had withdrawal, and it gives me sympathy for them, right? When you're trying to get away from whatever it is, gambling or sugar or whatever has got your goat, right? Most humans have some addictive behaviors, right? So you got to express some sympathy with them. But I think I inherently understand. I'm like, oh, well, that's why it didn't work. Oh, yeah, that's exactly why it didn't work. And then you focus on the things that they did succeed with, right? Whenever somebody says, oh, I quit for 3 days, one of my first questions, oh, well, what do you think you did that made that successful? Oh, it wasn't very successful at all. Well, 3 days is a pretty long time to go without a cigarette. Like that's a pretty good success. Oh, you went 2 weeks? Wow, most people can't make it 2 weeks. And suddenly you're expressing empathy. You're sitting down. You're getting inside their head. Again, it disarms a smoker when you ask them, what is it that you like about smoking? What would you have to give up to quit smoking? They get totally disarmed by that question because they're like, wait, you think that I might be enjoying this for a legitimate reason? Oh, yeah. People smoke for legitimate reasons. There may not be, it's not a healthy choice, but they do smoke for legitimate reasons, right? So that's my typical approach. A lot of that's that motivational interviewing. You roll with the punches, you try to get to where they are, and then you try to lead them in a healthier direction.